So next is slow transit constipation. It's V16. How would you manage a patient with functional constipation referred by a GP? What are the causes? Functional constipation is due to either slow colonic transit problems or problem with the rectal evacuation or both. So secondary causes of slow colonic constipation are neurogenic, like Parkinsonism, multiple sclerosis, spinal cord lesions, and diabetic autonomic neuropathy, and endocrine causes hypothyroidism or hypercalcemia, and anatomical strictures and ganglionosis like Hirschsprung disease, and drugs are anticholinergics, opioids, antihypertensive, and antacid. How will you assess the patient in the clinic? So take a history to exclude the red flag symptoms like unintentional weight loss, unexplained iron deficiency anemia, change in bowel habit, bleeding per rectum. Ascertain the degree of constipation by Rome 4 criteria. If patient score 2 or more than 2, then patient have functional constipation. So that this includes 3 stools per week and 25% sitting in the commode and needs training, and feeling of some obstruction and blockage, feeling of incomplete evacuation, and hard and lumpy stools. And then you have to ask about the history of prolapse or manual evacuation and previous laxatives that have been tried, and exclude the secondary causes listed above, systemic diseases, and examine the patient and feel for anal sphincter tone and sensation and prolapse. Request full blood count, urine ease, calcium and thyroid function test. And what investigation would you request? So exclude colonic pathology first by doing colonoscopy. A transit study should be conducted by Arhan's method that take 10 markers are ingested on 6 consecutive days, and an abdominal x-ray is taken on the 7th day. Counting the number of markers and multiplying by 2.4 gives the colonic transit time in hours. Delayed colonic transit is defined as time more than 48 hours on 20 residual markers on day 7. What other conditions need to be excluded? Isolated slow transit constipation is now thought to be relatively uncommon, so less than 5% in originator from the Oxford. Other disorders which give rise to the obstructive defecation are anismus and internal rectal prolapse and need to be excluded. A significant proportion of patients previously diagnosed with slow transit constipation actually have constipation secondary to the outlet obstruction. How would you manage a patient with isolated slow transit constipation? So ensure adequate fiber more than 20 gram per day combined with sufficient fluid intake, that's 2 liter per plus, and regular physical exercise. However, these lifestyle changes are rarely sufficient to improve the symptom. Then start osmotic laxatives, lactulose and polyethylene glycol, and then refer the patient for biofeedback, which focuses on the abdominal and pelvic coordination. Is also being offered in some specialists and has shown some benefit in selected patients. And is there any role for sacral nerve stimulation in the management of patient with slow transit constipation? Several studies have shown improvement in the symptom of patient with medically refractory slow transit constipation with the use of sacral nerve stimulators. And first they have a trial period of 2 to 3 weeks, and then if more than 50% improvement in the symptom, often used as an indication for permanent stimulation. If these don't work, then we can talk about patient with the antegrade colonic enema by making a small stoma through the stump of the appendix in the right iliac fossa, and patient can use as per need antegrade colonic enemas. And sometimes patients are too fed up, and we can offer him defunctioning loop ileostomy because it's a reversible thing. And the other thing is that last result is we should resect the colon and make an ileorectal anastomosis. Thank you.